Somatoform disorders.
Introduction. Somatic symptom disorder is a condition in which a person's somatic or bodily symptoms cause distress or disruption in physical health that is not consistent with a medical disorder, which only means that an individual may experience bodily symptoms of pain, but there are no diagnoses that can confirm their pain. The symptoms can range in severity from mild and frequent to chronic and severe and are out of the individual's conscious control. These symptoms cause a significant amount of distress and may or may not be linked to a medical condition, mental disorder, or other substance abuse condition. These conditions can cause an individual extreme mental distress and significant impairment in everyday functioning.
Types of somatoform disorders. There are 7 types of somatoform disorders distinguished by thoughts, emotions, and actions related to somatic symptoms. They are broadly classified into involuntary and voluntary types of somatoform disorders based on how people experience their symptoms. First up, we have the somatization or the somatic symptom disorder, which includes physical symptoms. It occurs when a person complains continuously about physical symptoms, even when there is no physical condition present to cause it. These symptoms may persist for several years and involve pain, stomach complaints, and sexual issues. Then we have the convulsion disorder, which includes neurological symptoms. It consists of your motor and sensory functions. It occurs when physical symptoms mimic the symptoms of a neurological disorder even when it is not present. The symptoms may include paralysis, vision or hearing loss, or seizures. It is generally the result of trauma and the way it has impacted a person's life. Next up, we have pain disorder. It is characterized by recurring pain in one or more regions of the body with no known cause. Based on how preoccupied a person is with their symptoms, we have hypochondriasis or the illness anxiety disorder. It occurs when a person believes that the normal bodily signs or minor symptoms are evidence of a severe illness, even when medical assessments say otherwise. The physical symptoms experienced in this may comparatively be mild or absent. Under voluntary types of somatoform disorders, we have the fictitious disorder, wherein a person takes up a sick role. It is a serious mental disorder in which someone deceives others by acting sick, or they might even injure themselves to appear sick. Fictitious disorder can also happen when family members or caregivers falsely present others, such as children, as being ill or impaired. The symptoms can range from mild, that is slight exaggeration of symptoms, to severe, which is also known as the Munchausen syndrome. The person may make up these symptoms or even tamper with medical tests to convince others that medical treatment is required. Even though people with fictitious disorder know that they are the ones causing their symptoms, what they don't understand is why they are doing it. Next, we have other specified somatic symptom and related disorder. This includes disorders which meet many but not all of the criteria for a particular type of somatoform disorder. These may include brief somatic symptom disorder, brief illness anxiety disorder, and illness anxiety disorder without excessive health related behaviors. And lastly, we have unspecified somatic symptom and related disorder. This applies to individuals who have symptoms that do not meet the full criteria for any of the types of somatoform disorders mentioned. The diagnosis for this should only be given in unusual situations or situations when there is insufficient information present. Symptoms. Thoughts, emotions, and behaviors associated with somatoform disorders may consist of the following: persistent worry about possible sickness, interpretation of normal bodily sensations as an indication of severe physical sickness, fear that the symptoms are dire or life-threatening in the absence of facts or medical confirmation, mistrust of medical assessments and treatments, excessive visits to a physician or hospital that never alleviates the concerns, and more significant impairment than what is commonly expected from a medical circumstance. The symptoms include that people will constantly worry that they are suffering from a possible sickness. They feel that the normal bodily sensations and the symptoms that they experience are an indication of a severe physical sickness. When they go for medical checkups and they find out that there is no underlying cause for the symptoms they are experiencing, because of this they might feel that they are trapped in a life-threatening situation, and they will feel that the reports are inaccurate because it does not explain why they are experiencing the symptoms. And because they feel that the reports are inaccurate, they might go for checkup.
Causes. It is not precisely clear what causes somatoform disorders, but it is believed that there are several contributing factors. Genetic and hereditary factors such as hypersensitivity to pain sensations may be involved. Family influences can also be another contributing factor. A pessimistic individual can influence how illness and physical symptoms are perceived. Increased attention to bodily symptoms and sensations when a person has difficulty identifying, discussing, or processing emotions is often involved. In other cases, a somatoform disorder may develop in a subconscious effort to garner extra attention because of their perceived illness. Diagnostic criteria. To be diagnosed with a somatoform disorder, a person must display at least one somatic symptom, such as pain or sleepiness. It should cause significant distress and negatively impact one's daily functioning. They must also have extreme and unrelenting thoughts about the severity of their symptoms, experience elevated levels of anxiety about their health, and spend an excessive amount of time on symptoms or health. Symptoms must last longer than 6 months, though the intensity of symptoms may fluctuate during this time.
Comorbidity. Somatoform disorders often co-occur with conditions such as anxiety and depression. While treating the somatoform disorders, it is important to look at the co-occurring mental conditions as well to make the treatment more effective. In some cases, these co-occurring mental health conditions might actually be the underlying causes of the somatoform disorders. Somatoform disorders can also co-occur with substance abuse. There is a strong association between pain disorder and opioid dependence in particular. Alcohol and benzodiazepines are also commonly correlated with somatoform disorders.
Risk and prognostic factors. Temperamental. The personality trait of neuroticism has been identified as an independent risk factor of a high number of somatic symptoms. Comorbid anxiety or depression is common and may worsen symptoms and impairment. Environmental. It is more frequent in individuals with few years of education and low socioeconomic status, and in those who have recently experienced stressful life events. Course modifiers. Persistent somatic symptoms are associated with demographic features like sex, older age, features mentioned in the environmental factors, unemployment, etc. A history of sexual or childhood abuse, concurrent physical illness, or psychiatric disorder, social stress. Cognitive factors that affect clinical course include sensitization to pain, heightened attention to bodily sensations, and attribution of bodily symptoms to a possible medical illness rather than recognizing them as a normal phenomenon or psychological stress.
Culture and somatic symptoms. Anthropologists who have researched different cultures around the world have found that the way in which people describe their distress and the symptoms that they experienced are influenced by the cultural beliefs and the manner in which health concerns are treated in a particular culture. Some individuals may report bodily symptoms, while others may report the emotional concerns depending on the way their culture addresses them. Many cultures show some of these bodily presentations. There is a Korean condition called hwabyang that includes stomach distress, headaches, and other pains. People experience this as a result of not expressing their anger or resentment that results as a mass in the chest. In Nigeria, there is a condition called brain fog. It is experienced as a heaviness or heat in the head associated with an effort of studying. This is most commonly reported by individuals who are first in their families to become educated because they have a lot of pressure from their families to do well. In South Asia, there is a belief that the vital essence can be lost through semen. It is believed that the semen can be lost in urine. This is called dat and is experienced as fatigue and weakness as well as anxiety and depression. Here we have some case studies for you. Case 1. Eloise, a 20-year-old girl, had trouble walking. Her condition developed over 5 years to such an extent that she would fall to the ground without any support and had to crawl to get from one place to another without help. After being told by several doctors that she was perfectly fine and there were no physical symptoms for her condition, nothing seemed to work on Eloise. This is a classic case of conversion disorder. Although she wasn't paralyzed, her specific symptoms included weakness in her legs. This particular type of conversion symptom is called aesthesia abasia. Case 2. During her first clinical rotation, a 25-year-old third-year medical student in excellent health was seen at her student health service for intermittent abdominal pain going on for several weeks. She claimed no history of similar pain. Physical examination revealed no physical problems, but she told the physician that she had recently separated from her husband. The student was referred to a psychiatrist. She was taught relaxation techniques and given supportive therapy to help her with her current stressful situation. The student's pain subsequently disappeared and she successfully completed her medical school.
Case 3. Rosalind Newman came to her university's student health service because of a stutter. This was remarkable because she was 18 and she had only been stuttering for 2 days. It began during a class when a discussion on sexual harassment was going on. The participants were asked to comment on the topic. When Rosalind's turn came, she stuttered so badly that she gave up trying to talk at all. After being asked about the past by the counselor, she confessed that when she was young, a friend of her father's was invited for dinner. The man was invited on various occasions. One evening, he consumed too much wine and was put to bed on their living room sofa. Rosalind awakened to find him lying on top of her in her bed, his hand covering her mouth. She was never certain whether he actually entered her, but his struggles caused him to ejaculate. After she told her mom, she assured Rosalind that she was just dreaming about the incident. Case 4. Gail was married at 21. She felt weak and somewhat neglected and suffered from low self esteem. An older stepbrother had berated her when he was drunk. Her mother and stepfather completely refused to listen to her. When she got married, 3 years later, she went to a clinic complaining about stress and anxiety because she found her job stressful. Then she found out that her husband was having an affair with his ex, but had later stopped seeing her, but she couldn't get it out of her head. It soon became clear that she had major concerns about her health. Whenever she experienced a minor physical symptom, she would think of it in terms of extreme illnesses. She left exercise, drinking, and laughing, afraid that she would stop breathing due to the breathlessness experienced. She was obsessed with diseases and their symptoms and would try to notice them in herself and everyone around her, including her dog. Gail's fears developed during the first year of her marriage when she learned of her husband's affair. She visited a lot of doctors, but nothing came out of it, and she was chronically miserable. Prevalence. The prevalence of somatic disorder is not known. The prevalence of somatic disorder in general adult population may be around 5% to 7%. Females tend to report more somatic symptoms than males, and the prevalence of somatic symptom disorder is consequently likely to be higher in females.
Treatment. The treatment for somatoform disorders aims to enhance a person's daily functioning by reducing their physical symptoms or improving their ability to cope with them. The treatment plans for these conditions usually consist of psychotherapy as well as medication. Psychotherapy is beneficial in the treatment of somatoform disorders because physical symptoms are usually related to underlying psychological conditions. The most commonly used somatoform disorder treatment is cognitive behavioral therapy or CBT. This focuses on helping people change their thoughts and behaviors related to the condition. It also helps individuals learn how to decrease the preoccupation that they have with their symptoms while teaching them how to cope with physical symptoms and other emotional and mental concerns.
Antidepressant medication may also be used if a co occurring condition such as anxiety or depression is present. Medications alone can't resolve a somatoform disorder, but they can help alleviate the symptoms of associated co occurring conditions, especially when combined with psychotherapy.
Thank you.